Greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I'd like to talk this afternoon about more women TMJ cases. Seems like the percentage ended up being about 80 to 20% for men, and a lot more women had TMJ problems. That's very few things that men have less problem than women do, but anyway, that seems to be the way it worked out. So I'm going to show another lady's case. It's just a simple deep bite case. Let's see if we can get this thing across here. I'll have to. Okay, here is the lady that has the TMJ problem. Very nice lady. She's got her head cocked up, but she's not kind of sticking her nose in the air like that. Real nice lady, and good facial features. No problem there at all. You look at it, and if you go to the smile. Now that's where the problem is. She's got a deep bite, and she's got her mandible locked back where she can't bring her lower jaw forward and chew it all, and that's the problem. So let's show that, show what her dental problem is here. It's pretty simple. If you look at this, I mean, you've got a deep bite. You can't even hardly see the lower front teeth underneath there, and the upper teeth are crumpled in over that. So it's kind of a deep bite, class 2 division 2 type situation. But the jaw cannot come forward, and so the condyle is pressed back on the retrodiscal tissue and causing problems. And you can see somebody come in like that, and you just touch them right here in front of the ears and have them open and close kind of slow, and you can almost tell exactly what's going on. They're having some pain on one or the other or both of the joints like that. So if you just get the teeth up out of the way and straighten them out, and the jaw is free to move forward in there, then the problem goes away. You can do it with a splint. You can open this, and we usually use the splint just to make sure we had it solved before we started the orthodontics, but a lot of times we would just do the orthodontics, and that would correct the TMJ problem. We're going to jump through the regular orthodontic procedures, but we use an intruding wire on the sides. We would hook up from here, as you see, and come out with a wire that was going way up here. We reach down and pick these teeth up with that. It pushed down on this same thing down here, and we would lower the lower teeth, raise the upper teeth, and that procedure we've shown many times in many of our videos, so we won't even cover that. And from the other side, the same thing. And when you do that, the jaw is going to move forward, and this lower molar will come somewhere around like this. You see the way it should. And so this jaw is going to move out, and these teeth will move out, move further, and that'll allow the lower jaw to come forward, and it gets the condyle. Of course, when you move this part of the jaw forward down here, it works on the condyle. I can't draw that on there right here, but it pulls that condyle off that retrodiscal tissue. And I've had patients, absolutely, if you got them opened up and pulled the jaw forward, if you did it with a splint, but a lot of times if you make a splint on somebody like this, with the lower teeth are up here, your splint's sublimin thick, so we'll just go ahead and start it, and then make the split later on. That's what you might do. So if you had to bring this out, you'd have her lower teeth coming up and touching up in here, and you'd have the bite open about like that. So your split would have to be real thick, to allow you to advance your lower jaw. So we go ahead, and if it's not painting too much, we'll put in the intruding arches in and build that in, and we can have her out of pain just in a very short time with that. So here's the way the upper arch looks, and we'll have that thing. It'll be way on out like this. It'll be lined up, maybe not sticking out that far, but they'll be out there for a good ways, and the lower can come forward too. Now in this particular case, we just used a step down arch in here to hold this gap open, and we took the retainer and put acrylic underneath it to keep the tooth above here from dropping down in this spot until she had something done like an implant or a bridge or whatever she wanted to put in that particular spot right there. Let's erase that, and we'll go on to the next. Now, here is the step down arch. You see it coming right here, comes up, and this holds it open, and you can hardly see this. A little bit of acrylic that we've got on the upper retainer, and that acrylic keeps this tooth from dropping down until she can get this either an implant or a bridge put in. And we kept this from dropping down. If we had put a block of acrylic in here, done the same thing, but they couldn't work on the bottom arch with that in there. So we just put a little acrylic off of the retainer from the inside. I think we show that here just a little bit, just another little trick that you would do. We left the brackets on there. Here we're putting the material on the tooth, and here it is. We just kind of came along on the retainer and added some acrylic here, and that'll keep this tooth from dropping down. If the retainer drops down, then this tooth here catches it, see, and that holds it in place while they work on the bottom arch and get the implant or whatever they elect to do. Then we got the lower teeth straightened out pretty good, and we probably left a gap in here this is an unusually small tooth. If they want to fill it in or crown it or do something to close that space, but the other teeth don't match up if I close the space. When you've got a small tooth like this, we'll leave it open, and they can enlarge that tooth with some type of crown or filling if they need to. Okay, here we go now. Now this, we got her out of trouble and everything's fitting good. When we took this picture, there's some dark material right between these teeth, but they're touching right here. This needs to be filled or filled in with some composite, but I've got the teeth actually touching there, and she's out of pain now, and she's in a situation where we could put her in a lower retainer and fix it up where she could wait until she could get her replacement down in that space. Now, when you look at the side view of this, you see this dark, I don't know whether it was just discolored or something. I should have scraped that off if it is, but it's probably a discoloration or stain on the tooth. And when you look at it from the front, you look like she's got a gap still there, but she doesn't. So here is the lady, and here's her smile, and the face is perfectly normal looking. And then when you see she smiles there that shows up at that dark spot right there, but that's really those teeth are together. And she's free of the TMJ problem, and she won't have it anymore as long as she wears that retainer and keeps that jaw in that forward position. So I hope you pick up on this, and if you do a lot of adult orthodontics, and even in young people, we have people with TMJ problems. It's just very common, and this is almost a dead cinch type case. You'll have them out of the pain if you just can advance the mandible, but you can't do it when it's like that. So you have to open them up, and then the mandible will come forward, and when it does, it pulls the condyles forward and gets it off of that retrodiscal tissue. So I hope you get something from this, and I'm going to sign off, and we'll hope to see you again. And we'd love for you to join our group and subscribe to this. And thank you again. We have a lot of folks in that, and I'll hope to see you later. Bye now.